I'm Dr. Mandeep Mehra from the Mass General Brigham campus here in Boston, Massachusetts, welcoming you back to Heart Failure Minutes. Today, we explore a frontier that challenges long-held beliefs about why some patients with heart failure endure repeated, escalating episodes of worsening disease, while some others stabilize and even recover. That frontier is now referred to as trained innate immune memory, a concept that the bone marrow itself remembers prior injury and responds with amplified inflammatory vigor to each new insult encountered. To help unpack this paradigm, I'm joined by Dr. Ameesh Isath, who is an advanced heart failure specialist here at Mass General Brigham. He co-authored this deep examination of this mechanism and its clinical implication in heart failure. Now, Ameesh, your work suggests that innate immune system, long thought to lack memory, actually holds a durable imprint of prior cardiac injury within the bone marrow itself. Can you explain how this trained innate immune memory operates and why it might intensify episodes of worsening heart failure?
So what we're learning is that the innate immunity that consists of macrophages, monocytes, neutrophils isn't just a first responder system that resets after each event. After an inflammatory or hemodynamic insult, it can store memory through epigenetic reprogramming of the hematopoietic stem cells in the bone marrow, and that persists long after the injury resolves. So when the body faces another stressor, ischemia, infection, arrhythmia, or even pressure overload, the response often becomes exaggerated. And the bone marrow releases monocytes and macrophages that are more inflammatory and more numerous than ever before. And these cells don't just affect the heart, they infiltrate the kidneys, the liver, the skeletal muscle, and fueling this multi-system injury that we often see in advancing heart failure. This could explain why a seemingly small trigger causes dramatic deterioration in some patients, why cardiorenal syndrome accelerates disproportionately, and why frailty and sarcopenia even often emerge in parallel with heart failure progression. Essentially, the bone marrow becomes primed, and each decompensation becomes more severe than the last one.
Very, very interesting concept. Clinically, it explains why we tend to see two different trajectories in different patients and the heterogeneity of such presentations, those who suffer repeated worsening episodes and then those who plateau. How might trained immune innate memory, perhaps through biomarkers like CHIP, for instance, explain this difference in many ways?
And this is one of the most important implications of the trained immunity model. Not everyone's bone marrow responds the same way. Some individuals carry CHIP mutations, particularly the DNMT3A and the TET2 mutations, which alter how their bone marrow respond to different stimuli. And these mutated clones produce macrophages that are more inflammatory, more durable, and more likely to cause this multi-system injury pattern. And this also may explain why some patients recover after an early heart failure decompensation, while others with similar presentations drift into this cycle of recurrent heart failure decompensations with progressive renal dysfunction and also frailty. CHIP might therefore serve as a biomarker who's vulnerable to that downward trajectory. Mm-hmm. And we already have evidence supporting this from the CANTOS trial, where interleukin-1 beta blockade produced far greater benefit in patients with CHIP mutations, right? That tells us these patients have an immune-driven disease biology that can be potentially modified. If we could identify these patients early via CHIP profiling or future innate memory biomarkers, we might finally understand who can safely recover or those patients who require persistent therapy or novel interventions.
Yeah, very interesting. We're bringing back the immune hypothesis, which for a long time has been debunked in heart failure. Now, if trained innate immunity is driving recurrent worsening, the natural question is, can we actually intervene on this? So what is the therapeutic landscape for modifying this maladaptive memory? Is it IL-6 inhibition, IL-1 beta blockade, which we really don't have many molecules to do that, or even something as generic as corticosteroids, at least in severe cases? Now, You are spearheading the Cortishock trial here at Mass General Brigham. Tell us a little about that.
I think that's the exciting part. If the bone marrow is driving a recurrent injury through trained immunity, then intervening at the level of immune activation might actually alter the disease trajectory. We are essentially looking at two different therapeutic pathways here. The first is the targeted cytokine blockade, which can be through interleukin-1 beta inhibitors, which we saw in CANTOS. The second is a broader immune suppression for patients in most severe inflammatory states, right? When decompensated heart failure starts tipping towards cardiogenic shock, short, carefully timed early course of corticosteroids may help blunt this pathological response. And this idea forms the basis of our upcoming Cortishock study, which tests early short course corticosteroids in decompensated patients in early heart failure cardiogenic shock. The aim isn't only to stabilize hemodynamics, but it's to ask whether we can interrupt this cycle of innate immune memory itself, and that may reduce the multi-system injury that happens as a consequence of that. If we see even a meaningful signal, whether it be clinical or even mechanistic, it could mark a start of new era in heart failure therapy, one that treats not only the hemodynamics, but also the bone marrow biology that remembers and amplifies each injury.
Wonderful, wonderful. Thank you so much, Ameesh, for guiding us through this emerging lens on heart failure progression. Very, very important concept indeed. The notion that the bone marrow remembers and that this memory may define who spirals and who stabilizes and who recovers marks a conceptual shift in how we understand worsening heart failure. As we begin intervention trials such as Cortishock, for instance, we move away from observation to just intervention. If we can modify the maladaptive immune memory response that fuels recurrent heart failure episodes and in fact amplifies them, we may finally change the trajectory for patients caught in this inexorable cycle of progressive decompensation. This is Dr. Mandeep Mehra from Mass General Brigham signing off for now. Until next time.